Good evening, everyone. I welcome you all for joining for today's masterclass in critical care. So every Tuesday, I'm Dr. Karthik. I'm a critical care consultant and head of the department at Yashoda Hospitals, ROME GINA. And I would like to invite you all for today's masterclass. And today's topic is an interesting one. We have every Tuesday evening, we bring forth interesting, relevant, and up-to-date topics in the field of critical care, wherein our experts who are seasoned examiners conduct the viva sessions in the important topic of critical care, wherein the examiners try to test the critical care residents who are exam going. And this very webinar has been designed with critical care residents who are going for their examination and enlightening them about the important questions that they would face in these very important topics. So today's discussion would be on the important topic of acute exacerbation of asthma and COPD. Today, I'm delighted to welcome our distinguished panel. Today, we have Dr. Suresh Ramasubban. Sir needs no introduction. He's a very senior examiner, a pulmonologist and critical care physician at Gleneagles Apollo Hospital in Kolkata. We are also joined by Dr. Rinoy Chandran. Dr. Rinoy Chandran is a consultant and head of department at Aster MIMS, Kannur. They will be the examiners for today. And I will be moderating the session. And the case presentation will be done by two young budding intensivists, Dr. Devanand, who is a pulmonologist himself and doing his IDCCM residency in Aster MIMS, Kannur, and Dr. Sajan Rahman, who is doing his DRNB critical care at Aster MIMS, Kannur. And on behalf of Yashoda Hospitals, our coach director, Dr. Venkat Raman Kola, and myself, we would warmly invite you all for today's webinar. So we will start off today's webinar, and I will be handing over the discussion to the examiners and the students. Dr. Devanand and Dr. Sajan would start off their case presentation. Dr. Devanand, over to you.
Okay, sir. Thank you, sir, for the introduction. So we'll be starting the case. Can I directly start?
Yeah, please.
Yes, please.
Sir, is the screen visible, the PPT visible?
Yes, Dr. Devanand, your screen is visible. Can you make it full screen? Yeah, you could start. Your case scenario is clearly visible to all of us.
Okay, sir. So I'm presenting a 61-year-old gentleman, resident of Payyanur. He's a known case of diabetes, hypertension, and chronic kidney disease. Retired businessman by profession. He presented to the emergency department with chief complaints of cough with expectoration since 3 days, shortness of breath since 2 days, drowsiness since 1 day. The cough with expectoration was started, it was acute onset. It was since 3 days, mucoid in consistency, scanty, yellowish, non-foul smelling, non-blood stain. It was associated more in the morning. There was no postural variation. It was aggravating on exertion and was relieving on rest. The shortness of breath was since 2 days. It was gradually progressive from grade 2 to grade 4 MMRC. It was associated with wheezing episodes. There was no history of orthopnea, PND, chest pain, or palpitations. And the bystanders also noticed drowsiness since 1 day in the form of decreased top. So moving on to the past history. Patient is a known case of diabetes since 20 years on tab metformin 750 mg once daily. Hypertensive since 15 years on tab cilnidipine 10 mg once daily. It's a known case of CKD since 10 years on medical management. Known case of COPD since 3 years, and patient has had similar complaints in the past with recent 2 hospital admissions in last year, and he is taking MDA formoterol plus budesonide 6 mcg and 200 mcg respectively, but he was a bit irregular in his medications. And he's also known case of coronary artery disease since 10 years, for which PTCA was done 4 years back, and patient is on tab aspirin and tab atorvastatin for those. And known case of peripheral vascular occlusive disease since 5 years, for which left BK amputation was done 3 years back. And he's a known case, he's an obese with history of daytime sleepiness, snoring for 2 years, but it was not evaluated further. Moving on to the personal history, he takes mixed diet and his appetite has decreased since 5 days. Bowel and bladder habits are regular and sleep is bit disturbed since 2 days. And he is a reformed smoker who quit smoking 2 years back with a pack years of 40, and he is a non-alcoholic. So my provisional diagnosis from the history will be acute exacerbation of COPD.
Any other differential diagnosis?
Since due to lot of he's a known case of CKD, he's a diabetes, he's an immunocompromised state. So any community occurred pneumonia of short duration can be another differential diagnosis.
Anything else?
The background of long-standing diabetes mellitus, CAD itself can be a cause presenting as a congestive cardiac failure.
Very so myocardial infarction, heart failure would be, and pneumonia would be the main thing. But yes, acute exacerbation of COPD is the number one thing. Pulmonary embolism?
That is also a possibility, sir. It can be a non-infectious cause of a similar presentation.
Correct. So, and obviously the other important thing is these are not only, which might be the correct diagnosis, but they not only may be the mimic, but they can also be the precipitant of the COPD.
Yes,
So
yes.
in this case, the precipitant seems like an infectious precipitant, but so again, you have to remember all these things. Okay. So fair enough, it is straightforward. So asthma and COPD, any other way in which you can confirm the diagnosis? How do you confirm that this is COPD and nothing else at this point in time?
We can confirm by spirometry.
So don't bother. So I think what we want you to say is that these are clinical diagnoses without any disease-specific confirmatory laboratory or radiographic findings. Okay, COPD is a clinical diagnosis, especially COPD exacerbation. So how do you define COPD exacerbations?
Any worsening of increased sputum volume, increased sputum purulence, or increased shortness of breath, which has happened in the last 14 days, for which a change of medications was needed. It's called exacerbation of COPD.
So Devanand, is there any way, how do you differentiate it from an episode of bronchial asthma, or how do you differentiate asthma from COPD?
Asthma, the presentation will be a little earlier. The patient mostly will be in 20s. There will be absolute symptom-free intervals between the episodes, exacerbations, and there will be family history. There will be history of atopy, allergies. But in case of COPD, it will be more of age will be more than 40. Then they'll be symptomatic throughout, and from the baseline symptoms they will have an exacerbations. And next will be history of smoking, history of any pollutions, and in spirometry there will be reversibility in asthma, but there won't be reversibility in COPD. But during exacerbations they can't perform spirometry.
And moreover, in COPD, the symptoms will be progressive.
In COPD exacerbations.
Sir?
Sorry, sir.
Okay, then let's define this once more. So COPD exacerbations are defined as episodes of increased dyspnea, cough, or sputum production or change in consistency. That's the simplest definition. They are often accompanied by tachycardia, tachypnea, or both, but it is three things: a increase in dyspnea from its baseline, increase in cough, or change in consistency of the sputum. That is the definition of a COPD exacerbation. We'll talk about what is the ROME criteria for severe exacerbation.
That's for mild, moderate, severe. There are
Correct. So we'll talk about that, but that we don't know. You haven't presented the physical examination, so we don't know. And acute asthma exacerbation is defined as a symptoms of episodes of increased symptoms, which is shortness of breath. The three cardinal symptoms of asthma are shortness of breath, cough, and wheezing. So any increase in any of these three is called as, or a change in treatment is called as asthma exacerbation. So you're requiring a change in treatment. So I think for critical care physicians, it's important to define and know these definitions very clear. But when you present the physics, so I think I agree with the presentation. This is a very beautifully presented case of COPD exacerbation. There's no doubt in it. But you should keep your mind open because in the exams we'll ask you what are the differential diagnoses and which may act as either a mimic or a precipitant. Both are the same. The patient can have a mimic, can be a precipitant, can be a pulmonary embolism, and a mimic can also be a COPD, can also be a pulmonary embolism. So that is very, very important. At the end of history, you have to do it. And as critical care physician, next, when you present the physical examination, we want you to classify this at the end of it as severity and why are you calling it as severe. So I'm going to give you the question first and then you present. All right. Go ahead.
So can we move forward, sir?
Yes, please.
Okay. So on arrival to emergency department, patient was drowsy but arousable. He was febrile. Pulse rate was 110 per minute, regular rhythm. BP was 130/80 millimeter of mercury. Saturations were 82% on room air, and respiratory was 32 per minute. On general examination, patient was well built, well nourished, and BMI was 38 kilogram per meter square. There was no pallor, icterus, cyanosis clubbing, but there was generalized pedal edema. Moving on to systemic examination, patient was drowsy but arousable. GCS was E4, V4, M6. He was obeying commands. There was no focal neurological deficits. On cardiovascular examination, S1, S2 were heard. There was no murmurs. JVP was not traced. Respiratory system, patient was using accessory muscles of respiration. There was bilateral polyphonic rhonchi was present along with coarse crepitations. GIT, perabdominal, soft, non-tender. There was no organomegaly. So initially, patient was started with supplemental oxygen therapy with face mask at 5 liter per minute of oxygen.
Go back.
Okay, sir.
Now tell me, is it a severe COPD or exacerbation or not? Is it a mild or moderate or what kind of a COPD exacerbation is this? Would you admit him in the ICU? Would you admit him in HDU? Would you ask the pulmonologist to admit in the ward if you're in the emergency? Where will you admit this patient and on what is the justification that you're going to tell the family and to yourself and to your colleagues that this is a severe COPD exacerbation?
Sir, according to the ROME criteria, which was proposed by Gold in 2024, this can be classified under severe exacerbation, and because he is keeping respiratory rate of 32, which was more than 24. According to ROME criteria, sir.
Very good.
Saturation, it's 82% on room air. According to the ROME criteria, if it's less than 90, it's less than 92% or 3% less than the baseline of that patient. It's also there. And tachycardia patient's pulse rate is 110. It is above more than 95, and he's
drowsy as well. The sensorium is lower.
Not part of the.
It's not part of
criteria.
You also need ABG and a CRP to.
You need a CRP. You don't need an ABG.
Okay,
you need a VAS score or a visual assessment of his dyspnea score and a CRP more than or equal to 10. So fair enough, but he's got 3 out of 5. So he has by definition a severe COPD exacerbation. So he should be in a monitored bed. Fair enough. So that's very important. In the exams, we would expect you to have read the this thing. And now can I also, if this were an asthma case, Dr. Rinoy would also agree that we have to, how do you define an asthma exacerbation and severity of asthma based on the GINA criteria? So you told the ROME criteria for COPD exacerbation. What is the GINA criteria for severe asthma exacerbation? Or is it the same?
For asthma, sir, I'm not clear about the question, sir.
The question is, what is this severity criteria for asthma? So you defined the severity criteria for COPD. Very well, perfectly done. 3 out of 5, you got it. And for asthma, you require only 1. What is that 1 criteria out of the 4 that they have included in the Global Initiative for Asthma, that is GINA Guidelines 2024? Okay, so it is, if you don't know, again, same thing, it has respiratory rate more than 30 per minute. In COPD, it's 24.
Yes, sir.
All right, heart rate more than 120. In COPD, it's 95. And saturation is less than 90%, while in COPD, it is less than 92% or more than 3% change from baseline. And peak expiratory flow, which is easily done in asthma patient, less than 50% of their baseline. Any one of these 4 criteria is present, then it is called as a severe asthma exacerbation. Blood gases, what we want you to understand, and in the exam, please don't say blood gases are not required for assessing the severity of the exacerbation. It is a clinical diagnosis. All right. All right. Go ahead. Anything else that you want to add?
No, sir. He continues. They can continue.
So patient was initially started on supplemental oxygen therapy with face mask at 5 liters per minute of oxygen, targeting a saturation of 88 to 92%, and nebulization with levosalbutamol and ipratropium bromide, and budesonide, since patient was already taking budesonide and was started. Injection hydrocortisone 100 mg IV were given in the ER department, and his initial serum potassium was higher and corrections were given and repeat value was normal. And the ABG with 5 liter oxygen with face mask was pH was 7.22, PCO2 was 73, PO2 was 70, and bicarb was 22, which clearly indicates an acute respiratory acidosis. And patient was started on a non-invasive positive pressure ventilation BiPAP, and injection cefepime sulbactam 1.5 gram IV were also given.
Hold on there. Alrighty, now tell me the doses for nebulization. How do you give SABA and SAMA in COPD? What is the dose for an acute severe exacerbation of COPD?
SAMA mostly preferred is SABA preferred levosalbutamol. Here it was given 1.25 milligram, and you can, according to the response, we can give hourly to 2 hourly, and you can later change to 4th hourly or 6th hourly, depending on how patient clinically goes.
No. So please, all of you, please be very clear. The dose for salbutamol or levosalbutamol, if you're giving plain albuterol or salbutamol, is 2.5 milligram. If you're giving this levo, is 1.25. It's every hour for 3 doses, and then every 2 to 4 hours, depending on what you have. So if you have an asthma exacerbation, then you give it every 20 minutes for 3 doses. Otherwise, the exacerbation won't get better. There is probably, I'm not very sure with the budesonide, because in the Western world, we have good data, but I'm not very sure about the role of long-acting as a nebulization. An inhaled corticosteroid or a formoterol or a long-acting beta agonist in this thing, but we tend to practice a lot. So be very clear on the doses. How much of steroid should you give?
Prednisolone or equivalents of prednisolone 40 mg OD for 5 days, or equivalent dose
So
of
prednisone 40. So hydrocodone
40.
100 is for. Okay. So how much is that in prednisone equivalent?
So roughly hydrocortisone will be coming around 200 mg, sir. Like for like
That's in a whole day. That's per day, so it's all right. So you can give 100 IV BD. Fair enough. And ipratropium also the same is 0.5 milligram every hour for up to 3 doses. So we combine in our country with a combination of levosalbutamol and ipratropium every hour for 3 hours, then every 2 hours, and every 4 hours like that. Then we do this dose is very important. And they interpret the ABG once again. Are you sure it is acute? So for every change in
every 10 change in
for more than 10 above, pH should have fallen by
0.8.
Recording in progress.
0.08.
For every change in
0.08.
10 CO2, there should be bicarbonate will will increase by 1.
No. First
No,
is
pH, yeah.
0.08.
Very good. So how much should I have been?
So 10 for almost 7.22. You see, 7.26.
From the normal here, the
Not
PCO2 is
7.26.
almost 30 millimeter mercury higher. So
The P. So it
Hello?
should have been 7.16, and with 73, so it should have been even lower. Then you say what should be the bicarb for this is then probably acute and chronic. Then what should have the bicarb been?
Bicarbonate should have for every 30 increase of PCO2, bicarb should have increased by, for every 10 there will be increased by 1 in acute settings and 4 in chronic settings. So acute decomposition, bicarb should have been increased by 3, sir. So 24 around it would have been around by 27. So there is.
So why is this not? Is it 22, right?
Yes, respiratory acidosis with the metabolic.
Why is there a
acidosis?
concomitant?
Since he's a CKD, there can be bicarb loss, which can be contributing to the respiratory acidosis. Sorry, which can be
Maybe lactic acidosis.
Yes.
Fair enough. So that's exactly. Please interpret the ABG always fully. Do not assume that this is an acute respiratory acidosis.
Yeah.
So this is definitely an acute and chronic respiratory acidosis. Plus there is a metabolic acidosis
component.
also
Yeah.
component. And if you should be ideally be now doing the delta to see if there is a triple, because again bicarb is not fitting.
Yep.
So patient was started on non-invasive post-tipular ventilation BiPAP and injection cephalosporin sulbactam 1.5 gram IV was given. ECG showed sinus tachycardia. 2D echo showed concentric LVH. There was no regional motion diabetes. There was mild LV dysfunction, mild MRTR, and there was mild pH. IVC was dilated. Chest X-ray was done, and patient was shifted to ICU for further management.
Just curious, why did you start cephalosporin sulbactam?
Since patient is a non-COPD with recurrent admissions, there can be colonization structure with there can be underlying structural lung disease with pseudomonas colonization. So antibiotics.
So we prefer a BLBLI combination for us coverage as well.
All or piperazine tazobactam can be given since.
Yeah. How often were these exacerbations? Last few exacerbations?
He had 2 admissions in the last year, and he was admitted almost for 1.5 months back for his respiratory complaints.
Okay.
So he has had 2.
It's a frequent exacerbator.
Frequent exacerbator.
Yeah. In such cases, you should be expecting colonization with somewhat resistant organisms. Yeah.
Can we proceed, sir?
What other therapy can you offer at this time in the emergency for the exacerbation other than ventilation? non-invasive ventilation.
Other than NIV, O2 supplementation with Venturi mask is an option. Then other option could be high flow nasal cannula, sir.
Medication. We'll talk about
Medication.
oxygen respiratory support. What other medication can you use for an acute exacerbation of COPD, severe exacerbation, to prevent an ICU admission or to decrease the chance of
if conventional bronchodilators are not reducing the bronchospasm, we can go about medications like magnesium sulfate. 2 gram magnesium sulfate can be supplemented as a slow infusion. Then another choice is IV anesthetic.
2 gram over how many minutes?
20 minutes.
Yeah, 2 gram IV over 20 minutes. What does it do?
Bronchial smooth muscle relaxation.
So again, does it prevent your intubation, ventilation? What does it do?
We don't think there is a role for magnesium sulfate in prevention of intubation and ventilation, sir. But as for the relief of the bronchospasm, it can be used apart from the conventional bronchodilators.
So do you want to give IV ketamine, anything else?
IV ketamine is also an option, sir, as a continuous infusion with a proper monitoring.
No, not in asthma, yes, not in CO. Be very clear, the data, whatever is there for ketamine or volatile anesthetics, is all for asthma exacerbation, not for this thing.
CO.
And what about your favorite theophylline, aminophylline?
We have got concerns regarding those drugs because of the narrow therapeutic index, as well as the higher potency for cardiac adverse effects like tachyarrhythmias. So we don't use those drugs much these days. And,
here is also patient is non-invasive disease.
Wonderful. Alrighty, so I think you got it right. You need to give bronchodilators with dose of both this thing. Probably no role for inhaled corticosteroids when you're giving 40 milligrams of prednisone equivalent. But yeah, it's okay. You need to give broad spectrum antibiotics. You need to give magnesium if you just want to prevent ICU admission. But once you're critically ill, no use. And you started on NIV BiPAP. Okay. All right, go ahead.
So the patient was started on NIV support in view of type 2 asthmatic respiratory failure in PS pressure support CPAP mode with the EPAP of 5 and pressure support of 12 with a FO2 of 50 by ventilator. ABG after 1 hour was pH was 7.25, PCO2 72, PO2 was 50 and BiCAP was 18 per minute. Need of invasive mechanical ventilation was discussed with family, and they were not willing for the time at that point of time. Since it's a clear case of NIV failure, where the pH has improved much, and patient is still tachypneic and tachycardic, and the complete blood profile which was sent, it was suggestive of neutrophilic leukocytosis, suggesting an infective exacerbation of COPD. CBP was sent in view of to assess the total leukocyte count. If there is an infection, there will be bacterial infection, there will be mostly neutrophilic leukocytosis. And CBP will also give us an idea regarding the eosinophil count, which can predict the steroid responsiveness, and also to like for further prognostication for scoring systems like DCAP score and all, there will be eosinopenia. And RFT was sent. It was suggestive of elevated urine creatinine. Sputum for gram stain AFP culture was sent. Nasopharyngeal swab for COVID RT-PCR and influenza panel was sent, which were negative later, which came later.
So you are all critical care physicians. Are you happy with this ventilator setting with the BiPAP setting? Well, before you give up and say this is a failure, are you happy with this setting?
We have to start EPAP with a lower EPAP and then we have to increment. We have to increment with minimum EPAP and IPAP difference of 4, which can
So
increase.
when you set an NIV, so what is it that you're looking? You set it on an NIV, isn't it? That means you set it through a ventilator.
Yes, sir.
And this is a morbidly obese gentleman with
Yes, sir.
suspected sleep apnea also.
So they may require higher.
When you set the PS of 12 and a PEEP of 5, what is it that you're looking at on the ventilator?
So ideally, we have to start.
What is the target?
Your volume targets?
6 ml per kg, 6 to 8 ml per kg of tidal volume.
Predicted body weight.
Then better clinical response.
So if you are you're not achieving your adequate target volumes, what can you do in such case? Is there any point in changing the PEEP? Will that help?
Sorry, sir, I think your voice.
I think that's what the sir is asking.
Interface.
So the two things was. So when you do this, and you don't have to even wait for an hour. So the question that we ask is that if you're doing in the bedside, you got a pressure support of 12 and a PEEP of 5. So you got to tell us what was the tidal volume achieved. And because these people because he's got a BMI of 38 and he's got probable sleep apnea, there might be a requirement where the typical American board question will go, what is your initial BiPAP setting for a patient with OSA or what is called as OSA mixed sleep apnea. In the sense that OSA with COPD or OSA with OHS, the BiPAP settings are different than pure COPD. So this is something which you guys. So this is something which you should realize this in real life and also in the exams when you are answering this, because this is not a simple COPD here alone, because he's got morbid obesity and you also gave history of symptoms of OSA. So this is not a pure COPD also. So here the question is, when we look at the Esteban's trial of looking at how to titrate, you start off with a PEEP of 4, increase pressure support in steps of 2 starting from 8 till you get a tidal volume of 400 ml. So did you achieve a tidal volume of 400? Here there is a slight difference. How will you do this in case of a mixed sleep apnea?
In OSA or with OSA COPD overlap people, we have to start with a higher EPAP or PEEP. Will be around 6 to 8 centimeters of mercury. Then rather than in pure COPD, you can start around 2 to 4, and later we can titrate.
This is be very clear. When you have an overlap syndrome, start with a minimum of 8 of PEEP, and 8 to 10 would be the better one, and then subsequently keep the pressure support approximately 8 to 12, 4 to 8 more than that, and keep on titrating as you go up on the EPAP to do that. All right. So the difference between starting NIV in an overlap syndrome and NIV in COPD is that your initial PEEP is not 4 or 5, but it's 8 or 10. It's very important. And then because of its obesity, what we call as you might require a higher than normal pressure support also to get the same tidal volume that what you would normally get, because of the significant restriction that obesity possesses. So this is not as simple. You are very casual in saying this is NIV failure, you want to intubate. We should not be casual, and you should say, have I done enough? So should I normally, we don't do more than 20 pressure support, but whereas it is not, we have noticed in COPD patients, in outpatients, when we do BiPAP for hypercapnic COPD, pressures even require 28 to 32 is required on AVAPs and things like that. So this is a situation with morbid obesity, BMI of 38, before you call it NIV failure. All right. In the exam, the obvious question is how do you define NIV failure? All right. But before you call it NIV failure, what I want you guys to do is to optimize the setting of a BiPAP as a critical care specialist in this situation, which is not a pure COPD situation. All right. So here I will take, if you call it as COPD as NIV failure because of either the fact that the PCO2 has worsened, but I'm more concerned with the fact that the bicarb has worsened. So I'm not very sure this is an NIV failure.
Because he also have underlying CKD, acute and chronic CKD.
Yeah, but why in 1 hour from 24 to 18? No, but 1 hour, what could the CKD have happened? Your creatinine couldn't have jumped in 1 hour from 3 to 7.5. So why is this patient in metabolic acidosis? Is it lactate? What is happening? So again, we are being casual about the ABC. This is not a pure respiratory NIV failure. I'm okay with the 7.25. You started off with 7.28, 7.24, 7.24. 74 was the PCO2. Now it's PCO2 72. So I'm okay with it. So why are you calling it an NIV failure? You actually have metabolic acidosis. Now tell me, why is that there?
Our explanation was probable worsening of CKD.
So how can 1 hour COPD, CKD worsen? What disease, what nephrological condition will worsen in 1 hour?
Probably
Yeah.
lactates would have
Lactate,
been.
yeah. I think you should have looked at the lactate also here. That was probably increased here.
So which medication could have caused that to happen?
Can be diuretics or even the
No.
steroids.
No.
Specific, you have mentioned it.
Salbutamol. Yeah.
Yeah. All right. So the commonest cause would be you have nebulized him too many times, and probably there's albuterol leading to lactic acidosis, and that probably is an
Lactic
explanation
acidosis.
for the metabolic acidosis. So I will cut down on that, continue the BiPAP, and then maybe look at it, which is what the family luckily did for you.
Okay, sir.
Understood, sir.
Okay, sir.
Dr. Karthik, your mic is muted.
Yeah. Metformin, he's on metformin, sir. High dose of metformin.
That also is a possibility.
Yeah.
Absolutely.
Probably.
So again, as a critical care physician, please keep your antenna open. As a pulmonologist, I'm okay in saying this is NIV failure, but not as a critical care physician. That's how we add value to our ICU for when a pulmonologist is already looking after the patient. Remember, the value that we as intensive care physicians bring to the table is not to tell the pulmonologist who has done 3 years of DM in pulmonary medicine to tell how to manage COPD. How can you know more than him? Isn't it? So our value is to read the ABC properly. All right. What is the point in having a senior consultant in pulmonology who knows how to manage asthma and you telling him, sir, this is NIV failure? I don't think that is how they act. So you please understand, intensive care is about reading these numbers correctly. And if you have to correct it, as Dr. Karthik rightly pointed out, stop the metformin, correct the lactates, maybe require some fluids, maybe he hasn't eaten something, maybe there is a little infection more than what you are thinking, maybe there's an LV dysfunction, maybe albuterol is responsible for this lactic acidosis. I will work as an intensivist. Your focus should be very clear before you say this is a respiratory failure. But yes, you can use a Hackor score and say the pH is, heart rate is high and so on and so forth.
Acidosis.
All right. But okay, the question can also be phrased in the exam as, when you started on NIV support, what is your initial settings and what is your target? Okay, so target has to be clearly mentioned that your goal SpO2 is 88%. All right. Your target is to decrease the respiratory work of breathing to less than 22 per minute because that is a severity assessment. Your tidal volume should be 6 to 8 ml per kilogram and your pH should definitely come to more than 7.35. This is the target of non-invasive ventilation. This should be clear, crisp answer in the exam. Otherwise, you guys will find it difficult to pass.
Okay.
All right. Next.
So, patient is started on sulbactam, tabasthromycin, hydrocortisone, and nebulized sabasama and oseltamivir, anticoagulants for DVT prophylaxis, and he was started on enteral feeding through RTS. Patient was drowsy and refusing oral feeds. and cardiology consultation also sought and managed accordingly. And day 2, there was ABG was pH 7.15, PCO2 was 97, PO2 was 74, VICAB was higher, 33.
I'm not
Respiratory day
believing
was
any of your ABGs. I'm not believing any of your ABGs now. Either you have written it on your own. There is no way now the CKD has gotten better and now is in such contraction alkalosis. So please take it seriously. When you presented last time also, I had the same fight. No. This is not matching. When you even make up a story, think about making up a story. So you have said that the CKD, his bicarb was metabolic acidosis, went down to 17 on day 2. What have you done to got the bicarb? Or you give him bicarb?
No.
And what happened? Kidneys will take 24 hours to adjust to a new PCO2. It is not gonna, that's why chronic 1:4. Acute 48 hours, acute and chronic definition is 48 hours. So if you now say this is 33, is for every 10, this thing pH PCO2 should go up by, bicarb should go up by 4, but it will take 48 hours. This is acute. You had a bicarb which was 17 about 16 hours ago.
That was only in single ABG, sir.
2 ABGs. First was 22. Second was 17. Third is 33. So how do you explain it? See, exam gets stuck. I know that in the exam we don't give you such a, if it's a pure case, then you're looking at real life, then we want you to give an explanation. If it is a real life and this has happened in real life, then give me an explanation. I'm ready to believe it, but then you as a critical care physician should be able to give me a reason why from 22 it fell to 17 and from 17 it jumped to 33 bicarb. What could have happened? How did the kidneys was so fast? It was failing, it was CKD, and now next day he was so good, he compensated double.
Only answer would be bicarb infusion in this situation.
Correct. Agree fully. So somebody has given bicarbonate without you guys asking you guys. Or the first ABG was wrong. Anyway, so now he is definitely worsened from the CO2 and he is failed.
Tachypnea was persisting, tachycardia was persisting, pressure support was increased, and repeat ABG also showed worsening respiratory acidosis. And family was convinced for invasive mechanical ventilation, and patient was intubated and was kept on pressure control mode with pressure support of 12, PEEP of 5, respirator 14, with IE ratio of 1:3, FA of 60%. And after intubation, ABG after 2 hours, which was performed, pH was 7.34, PCO2 of 56, and PO2 was 64, and bicarb was 30. And patient was controlled on ventilation overnight.
So why do you think the NIV failure happened? Where did we go wrong?
Already in advanced case of COPD, there can be a higher chance.
All right, don't blame yourself all the time. And in front of a patient family also, sometimes, it's very important for you to understand that even with the best NIV settings, in the best NIV centers in the world, 25 to 30% of the people will fail NIV with a severe exaggeration. So please don't blame yourself all the time, though in this case, I might blame you. But most of the time, so you have to know this number, what percent, because when you explain to the family that I'm putting your father on or uncle on NIV, there is a 75% chance that this should work, but there's a 25% chance that this will not work. All right.
Okay, sir.
And in our countries, it might be a little bit more because our BiPAP settings and our respiratory therapists are not as good as they are in America. So you can say that, but this is very important to know. A COPD exacerbation, how many will fail NIV despite being in the best NIV center in the world, despite having a good NIV. All right. So yes, But yes, what you can say is, as we already discussed, the pressure support may not have been adequate for a morbidly obese patient. The critical opening pressure for the sleep apnea patient may have been inadequate. So the PEEP setting was inadequate and the pressure support setting was inadequate. All right, please understand this. This is not, again and again, I'm stressing, this is not a pure COPD. The message that whoever is listening should be that.
Okay, sir.
Exactly, sir. Exactly. Also, when even the patient is in BiPAP, you have to look at the volume, and if it is not improving, you have to increase EPAP. So only then it will open up and give you increased volumes. So I think, as sir said, the increasing PEEP would have helped this patient. So when you are ventilating, even if whether it is NIV or BiPAP for a COPD and an obese patients, you should always look at volume. If volume is not improving, what you can do is increase the EPAP. So that will open up, as sir said, that and help you increase the volume.
Yes, sir.
So the critical opening pressure for most of the unknown CPAPs is about 8 to 12. So you don't know the critical pressure at which open, but 8 is the bare minimum CPAP that is required for most of the sleep apneic patient that we titrate in the sleep lab. So remember that when you have a suspected OSA, the NIV settings are different than NIV settings for a pure COPD exacerbation. All right. So this is why this one, it may be an important. All right. How do you intubate this patient?
Sir?
How do you intubate this patient? It's not easy to intubate these patients. He's morbidly obese. He's a physiologically difficult airway. So if you're in a critical care exam, and if you have an anesthetist as an examiner, the exam will go towards how to intubate a morbidly obese COPD patient who is requiring so much. What drugs do you use? What is the position that you put the patient in? Please understand our specialty. Our specialty is not to write patient was intubated. We are the one who is doing the intubation. You cannot tell your colleague, go ahead, intubate the patient.
Yes.
So there is nobody behind you. So would
first
you
of
use
all,
RS,
it's
rapid
important to
sequence? Go ahead.
First of all, it's important to communicate with the family that in this particular scenario, this could be a difficult airway which we are dealing with. So combined with the decompensated systemic illness which this patient has, it could be more risky. That is the first thing we have to communicate with the family. And as far as the preparation is concerned, we have to get the difficult airway cart ready, and the choice of drugs would be to minimize, as this patient has already got a long standing history of diabetes and CAD. So the choice of drugs would be to minimize the from the COPD point of view, we would target drugs which would with minimum like histamine release, which might worsen the bronchospasm. And concerning the critical care aspect, we would choose drugs with minimum cardiac, which will cause minimum cardiovascular instability.
Name the drug. Don't go on a story. Tell me the drug that you'll use to intubate him. What induction agent?
Etomidate is one option which we'll use. Then another one is ketamine.
Which one in this situation?
Ketamine. It
Why?
also has a ventilator effect.
Very good. So we would like you to use ketamine to intubate this patient because of the bronchodilating effect of ketamine. Propofol can also be used if the blood pressure, but the cardiovascular effect of propofol is bad. So between ketamine and propofol, ketamine would be the preferred agent of induction in this one. So based on the Intube study, again, please do not throw numbers that it is difficult to the family. You have to tell exact numbers. So what is the chance that this patient will have a cardiac arrest or hypocardiovascular adverse cardiovascular effect according to various recent studies?
We are not so sure about that.
All right, please read. This is from Sheila ma'am. She'll be very upset if you don't read her own study. Intube published in JAMA. All right, 4% incidence of cardiac arrest for all these difficult intubation. 48% of complications. So please read those studies. It's published in JAMA. We would expect all of you to throw numbers at the patient, because when you intubate this patient in the middle of the night without a senior being around, without this thing. So it is important to understand that what is the number one complication you expect after you intubate this patient?
Precipitating right heart failure.
No, hypotension.
Hypotension.
Why?
Because
What
post
is
pressure
yeah.
ventilation can decrease preload.
So autopsy,
Especially-
dynamic hyperinflation is the concern, because when you bag them, you forget that they have COPD. You bag them a lot because it's a reflex to bag them a lot. All right. And obviously pneumothorax will be the other thing that you're worried about in a COPD and asthma when you intubate
Yeah.
them. All right. So always preload them with a little bit of fluid if you can, and keep vasopressors, norepinephrine ready. And the position for a patient to be intubated with a BMI of 38 is not the classical sniff position, but a ramp position. And that's something which, so we want to hear these words. Then only I know you have done a DRNB in critical care. Otherwise, I think you have done a DNB in pulmonary medicine or medicine.
Okay.
We want you to know that you have intubated this 38, BMI of 38. How did you position? So you are very lucky if you didn't position in the proper way. You are very lucky if you gave him midazolam and atracurium. Exam will go with you use rapid sequence or delayed sequence. What is your preference?
Always will be a rapid sequence intubation.
Not necessarily. All right. So that is why the question is asked this way. All right. So is there data for delayed sequence in COPD? What is the difference between rapid and delayed?
Rapid sequence means
I beg all of you DRNB CCM candidates to understand what our specialty is. It is the act of doing this which is important. Any physician will tell you put him on the ventilator, but you are the one who's putting him on the ventilator actually. So you have to know everything about this. So delayed means giving more time, additional time for between the induction agent and the paralytic agent. All right. And then we tend to, because in this situation, delayed sequence also gives us more time to additional time for pre-oxygenation, especially if they are also a very low oxygen. You can give an HFNC or continue with the NIV, and you don't have this thing. But then again, you might say that this is controversial. You can leave it, but there is data for delayed sequence intubation in COPD exacerbation. All right. All right, meat of the topic. How will you set the ventilator? And what is the goals of ventilation? One line. Because we're already late. We get stuck in ABGs. And you guys never pass. And then you complain why you're not
How will you
passing.
identify autopilot?
You can, if the expiratory airflow won't come back to the baseline, you can identify. And you can perform an expiratory hold manner to see if autopip is there. You have to hold for 2 to 3 seconds.
Dr. Sarjan, Dr. Suresh is asking you, what are the basic requirements of setup of a ventilator for a COPD?
What is the main goal? One line. One goal of ventilating somebody with COPD.
To prevent reduce dynamic hyperinflation.
Dynamic hyperinflation.
Very good. So that is very, very clear. It is not to correct the PCO2, but it is the goal of ventilation should be to limit hyperinflation. How do you do that?
To minimize auto-peep.
What settings will you use?
The expiratory time should be set more than the inspiratory time. There should be a higher inspiratory-expiratory ratio, and the
wait a second. You don't. You cannot set an expiratory time.
The respiratory rate should
Expiration
be
is spontaneous.
yes, sir. Yes, sir.
Ah.
The respiratory rate should be set in such a way that
no, always start off with the same thing. When you say what mode, whenever this question is asked in the Viva, please answer, and in real life, answer it in the same way in which you will do it. What is a mode? You probably use the paralytic, so the initial mode is always a controlled mode, sir.
Control mode, sir.
Most likely we will use a volume control mode, sir. All right, next is I will use a tidal volume of
6 to 8 ml per kilogram of predicted body weight.
Of ideal body weight. Respiratory rate of
10 to 12 breaths per minute.
Very good, but you set it at 14 here. All right, 10 to 12 breaths per minute is what you want to set it at. And then PEEP of
4 to 2 to 4.
If the patient is completely paralyzed and there is no spontaneous breath, ideally PEEP might not be even can be omitted. But if the patient has started breathing spontaneously, it is I'll set a PEEP of at least 80% of the auto PEEP.
We'll come to that part. Right now, it's only PEEP of normal setting, anywhere from 4 to 6 of PEEP is what you want. Already, what is the inspiratory to expiratory ratio that you want?
We would go with a higher ratio, sir. Ratios like 1:3 or 1:4.
So anywhere from 1:2 to 1:4. If you don't have an IE machine, but you have a PB machine, how much should be the inspiratory flow?
60 to 90 liter per minute.
Very good.
Is what I target.
And what last is, what is the trigger sensitivity you will keep?
25%.
Flow trigger or
flow?
What kind of flow is ideal in a COPD patient?
Decelerating flow is ideal because I want to keep the peak inspiratory flow.
No. Wait a second. We are talking about what is the flow sensitivity, not what is the I/E ratio. We assume that you are giving 60 to 90 liter per minute with a square waveform. All right, it is never with a. That's when you get the maximum least I time and the maximum E time. Okay. All right, decelerating ramp will make you I time will become very high. So don't do that.
Okay.
All right, please. I hope everybody understand that in a square waveform, where the peak flow 60 liters per minute will go at 0.6 seconds. So the inspiratory time is the lowest. If you have a decelerating time, it will take 0.8 seconds to deliver the same breath. All right. So when you want to decrease the I time in the COPD exacerbation, it is a square waveform. What I asked was, what is the trigger sensitivity? Whether you use, as sir asked, if you have to use a flow trigger, what is the flow trigger that you will keep? 2 liters per minute. All right. So please, see, you have to set everything. You have to set everything. So in this one, pressure control mode, fair enough. That's all right. But again, then you have to tell me what is the tidal volume. Again, you will say it is failing, sir, because we don't know whether it's generating 6 ml per kilogram or not. So these things are important to understand. All right.
Yes, sir.
Yeah, continue. Yeah.
So on day 3, the ABG was pH was 7.33, PCO2 was 40 with a PO2 50 and BICAP of 24. Sorry, that is wrong. And X-ray was showing some opacity. So HRCD just followed by bronchoscopy was done in view of increased purulence of ET secretions and worsening of clinical radiological profile, and BAL was sent for analysis. Lung UC showed bilateral moderate pleural effusion, and diagnostic and therapeutic thoracentesis was done bilaterally, which revealed translative effusion. And these were the X-ray and the CT on the lung cuts. There were bilateral upper lobe ground glass opacities were there, and later BAL analysis revealed a respiratory syncytial virus and was managed accordingly. And patient's generalized edema and it was increased and urine output decreased and was initiated on hemodialysis after nephrology opinion. And later patient underwent 3 repeated sessions of hemodialysis later in the course of hospital stay. And on day 4 admission, patient had episodes of hematemesis. Medical gastro consultation was sought. Endoscopy is done, which is
let's not start. We don't require from intensive care. The only question after that is what are you monitoring when the patient is on the ventilator? And then we'll come to how to wean. When do you decide to wean? So 3 questions and then I'll be done.
Okay, sir.
So patient's pH was on day 4 of admission. Patient's pH was 7.32, PCO2 was 56, PO2 was 72, and bicarb was 29, with a respiratory rate of 20 and pulse rate of 100. And patient was patient GCS was full, and then there was clinical improvement. Patient was extubated to NIV support with pressure support of 5 and PEEP of 5, and the ABG after extubation after 6 hours. pH was 7.43, which was normalized, and PCO2 was 59, PO2 of 93, and bicarb of 31. So we continued the NIV support, and the patient's general condition was improving and respiratory symptoms decreased. And at room air, his saturation was 90% with room air and was given intermittent bipump support. But since patient water switched to hospital of their choice near to their home in view of logistic reason, and he was switched to oral therapy.
Dr. Sajan, hold on. We're not concerned. If patient went home, I understand that. What we are concerned about is you as an intensivist. What were you monitoring when the patient was on the ventilator? Or you were not monitoring, you went home?
We were monitoring peak inspiratory pressures. We are monitoring if there is any auto PEEP per person, and the tidal volumes are adequate. And we changed from we were if the patient was ready to wean off from the ventilator.
The exam answer is very. Wait a second. The exam answer has to be crisp and clear. Sir, we were monitoring the patient on ventilator and assessing him for hyperinflation. And you stop. Then we ask, how did you monitor that? Then you say, sir, I measure the PEEP plat and intrinsic PEEP, auto PEEP by doing the inspiratory hold and expiratory hold very frequently. All right. Right. Then we ask what's the difference when the peak pressure is high and what the plateau pressure is low, and so on and so forth. All right. The word should be very clear in the exam what you are monitoring. All right. You are monitoring for patient for barotrauma and for dynamic hyperinflation. All right. So this is what you need to do. What will you do if you have got auto peak?
There were strategies.
What is the most important strategy you can do to decrease auto peak?
We can give bronchodilation.
Only one. No. Okay. All right. Agreed.
Anything
on the ventilator? Let me rephrase the question. Agree with you. Treating the disease is the most important thing. As a pulmonologist, I'll have to agree on that. That the best way to decrease auto PEEP is to treat the disease. Okay. But on the ventilator, give me one, and I will stop after that because it's 8 o'clock, and then I'm also tired. One method which has the maximum effect on decreasing auto PEEP.
Giving intrinsic PEEP of
no.
What else we can distribute for 40 to 60 seconds?
Can you do anything on the patient?
Hold for 40 to 60 seconds so that.
All right, you guys are multiple choice generation. Let me give you a choice.
Yeah.
Choice is between decreased respiratory rate, decreased tidal volume, or I/E ratio. Which one has the maximum benefit for the patient?
Decreasing respiratory rates.
Greatest impact. Which one has the greatest impact? Let me rephrase it. 3 choices. Decrease respiratory rate, decrease tidal volume, or decrease increase the I/E ratio.
I/E ratio.
I will stop if you correctly answer.
I/E ratio we can give up to 1.
No.
Decreasing respiratory rates.
Absolutely. Perfect. So please, everybody remember that the best way to decrease auto PEEP is to not between tidal volume and respiratory rate. Good data. There's a nice article in Chest published about 7-8 years ago, which will clearly tell you that the maximum, there's very nice graphs which will show you that the maximum benefit happens by reducing respiratory rate rather than by decreasing. I have my COPD PPTs, which will show, I have copied it from there. They'll show you the maximum impact. See, in MCQ, the word is very key. the max. We do all three. I'm not saying in real life we don't do all three. We decrease the tidal volume, we decrease the respiratory rate, we increase the I2E ratio, we give bronchodilators. But in an exam, we want you to tell us one thing or the most important thing. All right. Dr. Karthik, I'm going to stop.
Yeah. Yes, sir. I mean, you have covered all the pertinent and important topics, sir. There's not much I can add to whatever you have discussed. Almost you have discussed all the examination centric topics.
There are two more questions after that. One is, what is the role for ECCO2R? All right. In today's age, in ECMO, most of you work in a hospital which is ECMO capable. So you are asking, where is the role for ECCO2R? And the answer is, in a randomized control trial, there has been no benefit, but maybe there is some benefit in certain selected group of patients with hypercapnia whom you don't want to intubate and ventilate. Second is, what is the criteria of how do you extubate these patients? You don't have, when you fail an SBT, so you say that we can extubate them to NIV. The data for extubation to NIV is very strong in COPD. All right. Thank you.
Yes. Thank you, sir.
Yeah. So one more important aspect is about the nutrition. When you're weaning these patients from ventilation, you would like to keep your carbohydrate load a bit less so that they don't generate a higher amount of CO2 and helps in liberation. That is one aspect on the nutrition. Anything, Rinoy, from your end? Any your comments or a message to the students?
Yes, adding to especially for nutrition, you can to decrease the CO2 generated, you can maybe increase the fat percentage in the nutrition. And for these COPD patients, nutrition is especially important because most of them will be very much undernourished. So that part is also very important.
Yes,
From the beginning, you have to get nutrition.
Yeah.
Weaning, how will you wean these patients to what mode you will wean from a ventilator? Will you wean to room air or HFNC or NIV, which is the ideal one?
Preferably to a NIV. We would like to wean the patient to an NIV, sir.
Yeah. Again, weaning to immediately following extubation is the preferred one. And how do you assess when you can wean these patients?
Dr. Rinoy, your voice is breaking.
What are things you look for? Whether he is ready for weaning. What are the things you look for? Is he ready for extubation? Look for to assess their ability to wean. Yeah.
Yes. First concern would be the resolution of the primary pathology for which the patient was intubated in the first place. Then normalize the vital parameter. There should be no much hemodynamic instability. The ABG should be satisfactory, and the patient should be the sensorium of the patient should be full. The GCS should be full. Even though the patient is requiring vasopressors, it should not be the doses should not be very much high.
Okay. And able to manage. You should be able to manage his secretions well.
Yes,
should be able to protect the airway. And preferably all electrolytes or parameters should be optimized, which can help to wean.
Yeah, very good. That's it from me, Dr. Karthik.
Yeah, so there were some questions from the attendees. One of the student had asked whether your nebulizations can cause lactic acidosis. The answer is yes. So if you use antagonists like albuterol, they can cause lactic acidosis. To be precise, type B lactic acidosis. So that was one question that we got from the audience.
It's a very common question even in MCQs. Albuterol as a cause for lactic acidosis.
Yeah, then the one more question is there from the audience, like what analgesia and sedation vacation you will use. So I think I can rephrase that question. Analgesic of choice is what they are asking. There's not much debate about it. You can like use your opioids like fentanyl for analgesia and during ventilation and sedation vacation. I didn't understand the question. So it means to say that would you give sedation vacation to the patient? Yes, absolutely yes.
Yeah, I think it's so sedation. Dexmedetomidine is also one good option
Yes,
for
yes.
these patients. They has got some bit of bronchodilatory effect. And sedation vacation, daily you have to give sedation vacation. That's the protocol in every ICUs.
Yes. So,
this is for the readiness for extubation for all patients.
yeah, so this probably ends our webinar to today. We had an elaborate discussion on the topic, and I have to thank Dr. Suresh sir for having taken out his valuable time and spending with us and giving his tips. And now you know if Dr. Suresh is your examiner, what the sir will be asking you. So this has been a very informative as well as an educating session that we had, sir. Thank you for your time, sir, for taking out your time.
Thank you so much.
And I would also like to thank Dr. Rinoy Chandran for having taken out time for his busy schedule and conducting today's webinar. And big thanks to
I
even
thank you.
yeah,
I
thank you
thank the
to
organizing team also for allowing our students to participate in this. Thank you, sir.
Thanks, Dr. Murli, for having me on.
Yeah. Thank
Dr.
you.
All the
Thank
best.
you,
Dr.
Suresh sir.
Ramasubban, thank you. Yeah.
Karthik, 1 minute. Thank you, Suresh sir. It was an enlightening session for all of us. We again enjoyed your teaching, examining, and all. Thank you, Rinoy. It's thanks from the whole Yashoda academic team for all of you. Thank you.
Yeah.
Thanks.
Thank you.
Thank you, Devanand and Dr. Rajan.
Thank you,
I
sir.
mean, you have put up a good case, though there might be small lacuna, but that is understandable. And yeah, but do take care about the ABGs and the message. I think you would have understood to read ABG as a whole. And I would like to thank all the delegates and all the attendees that have joined today for the webinar. And every Tuesday, Yashoda Hospital will bring every Tuesday such important topics for exam going students. And thank you all for joining today's webinar. Thank you very much.
Thank you.
Thank you.